Welcome to the second session of the special eighth monthly webinar series, Delivering Cancer Care in the COVID-19 Era. Session 2 is titled, A Return to Operations Not as Usual, Practical Strategies for Cancer Programs. I'm Jen Wood, Meeting and Administration Manager for ACE, and I have a few housekeeping items before we begin. This webinar is being recorded and it will be posted to the members-only section of the ACE website. And we'll be pausing throughout this webinar for questions. So if you think of anything during the presentation, please submit your questions through the question box on the GoToWebinar toolbar. Next slide, please. For those of you not familiar with ACE, the Association of Cancer Executives is a national organization committed to the leadership development of oncology executives through continuing education and professional networking designed to promote improvement in patient care. Next slide, please. The ACE membership year ends on June 30th, and we're pleased to share with you that we have launched a new membership platform. Join or renew your membership to ACE for only $275 per year. For more information on membership benefits and to join, please visit cancerexecutives.org. Next slide, please. Please save the date for the 27th ACE annual meeting scheduled January 31st to February 2nd, 2021 in Rancho Mirage, California. Sponsorship and exhibitor opportunities are now available. We will be opening attendee registration later this summer. For more information about the upcoming annual meeting, please visit cancerexecutivemeetings.com. Next slide, please. Now it gives me great pleasure to introduce today's webinar moderator, Nancy Bookbinder. Nancy's 35 years of experience working in the oncology community includes consulting and collaborating with hospitals, health systems, physician practices, government programs, foundations, and national oncology associations. In 1990, she founded Oncology Resource Consultants and was the firm's president for 29 years. This past year, Nancy was principal with ECG Management Consultants and a co-leader in the firm's oncology consulting practice. Early in her career, Nancy served as executive director in both an academic and a community cancer center. She's a board member of the Association of Cancer Executives and serves on the Henrietta Lacks Advisory Board. Nancy is the first recipient of the Association of Cancer Executives Marcia Fountain Award for Excellence in Cancer Administration. We hope you enjoy the webinar today. Please take it away, Nancy.
Thanks, Jen. I too would like to welcome the participants to our second in a series of webinars brought to you by the Association of Cancer Executives for our members. I'm pleased to say today that we have over 90 people participating on this webinar. The goals of the webinar today are to share learnings and guidance from our two speakers and to hear from webinar participants. During this webinar, the presenters are providing polling opportunities. There will be 6 questions asked of participants during the course of the webinar, with participant polling responses shared. We will pause for your questions 3 times during the presentation and again at the end of the presentation. We request that you forward questions as early as possible to ensure the speakers have the opportunity to respond. I know those of us in oncology are not a shy group, so as soon as you think about a question you want to ask, please send it in to us so we can forward that to Matt and Jessica. I'm very pleased to introduce my former ECG colleagues, Matt and Jessica, who are both principals at ECG where they co-lead the firm's oncology practice. Matt Sturm brings his 17 years of experience, and he assists clients with developing and expanding their oncology programs through improved clinical coordination, enhanced physician leadership, and increased clinical capabilities. Matt has an established track record of developing innovative solutions to complex problems and focuses his career on improving access to high-quality clinical care. Matt's work has included developing strategic plans, providing support in launching new clinical modalities, and assisting programs with growth and expansion opportunities through acquisition and partnership. Matt regularly speaks at industry conferences and has authored numerous pieces of current trends in oncology for leading publications. Jessica Turgon, who will start the presentation, has developed comprehensive cancer programs in both community and academic settings. She helps clients develop oncology service line strategies and tactics for successful market growth, programmatic development, and the recruitment of top-tier researchers and clinicians. She has led major operations improvement initiatives that enhance patient access, increase physician productivity, and maximize revenue collection in both the hospital and physician practice settings. Jessica also led the development of an oncology service line strategy and management book for Health Leaders Media, Oncology Strategies for Superior Service Line Performance, and has published several articles on oncology transactions. Prior to joining ECG, Jessica was the administrative leader for several NCI-designated comprehensive cancer centers. And now, Jessica.
Thank you, Nancy. Thank you all. We are going to get into all of the challenges that you all are probably facing in your day-to-day operations. But want to start by asking you all, how many analytic cases do you typically see each year? So how many new cancer cases are diagnosed at your facilities? You'll see the poll online, and if you could select one, we'll jump into this. I think what we wanted to see, Matt and I have talked with many of you, many programs around the country, and folks are really seeing a lot of different things. The impact of the COVID-19 crisis is being felt differently, and we wanted to tailor some remarks to how the size and scale of organizations that we have on the line today. So Jen, do you want to close the poll and we'll see what we've got? There we go. Okay, so I think as many sort of the size and scale of programs that we see across the country, some of you maybe less than 1,000, but then we've got several of you on the phone and a prevalence of the group with large size cancer programs. So we'll tailor our commentary and then see if we can be helpful as we move through this. Thanks, Jen. I think at first, what we're hearing predominantly from everyone is that obviously existing cancer patients, some of them, their treatment was interrupted. We have found that in certain situations, treatment patients continue to come into the cancer centers for their infusion or radiation oncology treatment, but really the quarantining, social distancing affected patients from finding transportation in for their treatments, being able to make certain types of appointments, and then obviously with caregivers not being able to provide the necessary support, there were certain challenges. For new cancer patients, this is where we saw folks probably take their biggest hit, that cancer outpatient visits were down due to shelter-in-place orders, physician offices navigating the safety and PPE rules, and then also because the surgical volumes were cut, several cancer programs saw their new patient volumes drop as surgical and non-urgent cases were pushed off, given the ramp up for COVID response. And in all, I think on average, there were significant dives in outpatient ambulatory centers. As of early June, as you can see from the map, and you're all living this, there are considerable challenges in incident rates or significant variability in incident rates across the country, and every program is likely to have a unique story. We talked with several programs in the Northeast where are having significant patients, cancer patients with COVID come into their cancer centers, having to triage COVID cancer patients as well as non-COVID cancer patients and create the operations to support that, while others in more rural Midwest centers found that their total volumes dropped. COVID cases were minimal, but patients were really concerned about coming into the city to receive cancer treatment care. And so there were different types of responses given your market situation that we saw across the country. And accordingly, obviously, recovery strategies will need to be uniquely tailored to your specific circumstances, but we're trying to make sure that we can share some best practices, share some insight on the call today. So time for our polling question number 2. How much of a decline in ambulatory volume did your program experience in March and April? We're hearing different amounts across the country. Again, some as high as 50%, some as low as, more of a 10% in ambulatory volumes. Interested to see what folks are experiencing across the country. Jen, do you want to open the poll, please? And so again, I think this is what the challenging thing is, it's not a one size fits all. You all can see that there's really been a difference in response. Some folks have seen, looks like predominantly a lot of folks have seen that less than 20% of ambulatory drop, while others have really seen a significant, that 30 to more than 50% decline in volumes. And so given your situation, given your market, given what's going on, we're seeing a lot of differences in patients. This is also, hopefully you're going to also see a difference in response in patients coming back. We're seeing folks that are really reaching out to their patients, trying different strategies to engage their patients or newly diagnosed patients to come back into the cancer center or to access care in a different way. And we're going to talk a little bit about that. Jen, if you could jump back, please. So today, Matt and I are going to really lead through a couple key topics. We're going to touch on what folks are doing to support this sort of, I would say, the crush of patients that hopefully come back to you and then sort of eases that demand back to normal levels. Obviously, there's a thought that folks are going to come back over the summer and early fall. I know we're all waiting for the vaccine, so it really depends if we see that volume come back urgently or come back over time. Wanted to talk a little bit about clinical operations and the changes that we see are being put into across the country to manage patient safety and staff safety. Matt's going to walk through, facility designs, what organizations are doing to accommodate different requirements to keep patients and staff safe. We are seeing a ton of challenges around communication with family members. As you all know, usually it's the family members that are helping a patient through their care process, helping them through their visits, taking notes, understanding what's going on. And without visitors at this point, in many environments, there's a real gap in communication. And so having folks, communication with both families and patients, we're seeing folks implement different strategies to connect the dots. We also want to hit on workforce stability and what folks are doing to prepare their workforce in light of what's going on, and then obviously address safety and well-being as part of that. And then finally, there's a lot of opportunities to structurally look at different financial mechanisms to help maximize revenue in this time period. And we're going to talk a bit about that, particularly in telehealth and some of the recent changes in the marketplace related to payment reform. So a moment on telehealth. As many of you saw, I know maybe your in-office ambulatory visits dropped, but folks have seen 100% to 1,000% increase in the use of the telehealth platforms. We've had cancer programs that were doing 5 or 6 televisits, sort of just tipping their toe in the water, all the way be up and running and have much more in the line of 100 to 150 visits a day moving through their telehealth platforms. And that type of, what we're now seeing is that the speed of which folks pushed things out was unbelievably great. Now we're getting through a billing cycle. Now we're starting to see, are we getting paid for what we pushed out into the marketplace? How are we optimizing now this platform that we have? We had to react urgently to the situation that at hand, but now how can we optimize moving forward? Telehealth obviously has been embraced by many patients and providers for certain services. I think the fun part of this has been maybe those physicians that many of you around the phone may have struggled with of adapting to telehealth, but they're now your biggest advocates for telehealth services in certain situations. Obviously in cancer care, addressing certain types of services through telehealth and expanded services has been incredible. Survivorship, social work, clinical pharmacist follow-up, all different types of sort of services that a cancer patient may have had to come in really can be added and provide a value add to that patient through a telehealth type of visit. And so we're seeing a lot of different types of care models emerge with the advance of telehealth. We are seeing some organizations using remote monitoring devices to include sort of that, or to push sort of that healthcare at home model. Some of folks are taking it all the way to the hospital at home model. Some are stepping back and saying, how can I maximize my home health connections and or my monitoring connections through different types of programs in their community. We are starting to hear that leading centers are likely anticipating that some of that visit volume is going to stay telehealth for the foreseeable future. And then what does that mean when you think about staffing, as you think about adjusting your ambulatory footprint, as you think about providing that new care model? How are you going to navigate that as part of the new normal? And so with all that said, in a cancer care environment, we're starting to see different types of responses to telehealth. And I want to talk a little bit more about that as well. I think as an example, this is from a Midwest client of ours. You know, obviously, as soon as the crisis hit, there was a ramp up of services, particularly the right types of appointments that needed to allow patients to maximize their experience with their APPs or their physician teams. I think the unintentional opportunity that folks started to talk about is through telehealth, we can obviously not wear masks and have that much more personal relationship with others. I think what we're starting to hear is, well, how do you do this very efficiently? If I'm going to, we saw some organizations also use telehealth as a way to manage clinical teams and actually have their clinical teams not come in. So when what I would say is, we have a morning session that is telehealth driven. We have an afternoon session that might be in-house. Well, does that allow my doctor or provider actually not to come in and not to be in the facility, and that decreases my my threat to other staff members by having everybody in the facility at one time? And so what could we do from an at-home care providing, even for our providers providing care as part of this? This also has led, and I'll take a little bit of, to connect the dots a little bit from this example to others, but we've started to see folks virtually room patients and use this model now as patients are coming back. So do I have a virtual waiting room? Do I text the patient if they are going to be admitted to the waiting room? Do I have them accept and come into the waiting room, not only for the telehealth visit, but can I use these types of tools for in-person visits as well? And then obviously all the integration of the various platforms, if it's Zoom, if it's Epic through MyChart, if it is Cerner and Zoom, how are we using all the different technologies together in a blended way to optimize medical record and physician documentation, et cetera? One thing that keeps jumping up through all of this is, okay, yes, we appreciate all the telehealth, but we also understand that operationally, as patients come back in, as staff come back in, we're seeing a lot of focus on what is going to be our testing requirements. How do we think about managing and testing our patients, and then managing and testing our staff? So overall, for this example, is a pretty large hospital with 840 to 850 patients in the hospital at any one time. This is all patients, not just cancer. But the center experienced a 50% drop in its census and is slowly building back on, even with its telehealth program. So I think, fast forward to now, what's going on now? Everybody sitting around has experienced their great stories around telehealth. Now we're going through this, what I mentioned before, this first billing cycle, and what's going on. And so a comment would be, yes, all of the rules were loosened up through the COVID relief bill. Therefore, some of the requirements that used to really keep us away from using telehealth, particularly for Medicare patients, have all been removed. And many of these are, for example, telehealth services may now be provided by a new provider. You don't have to have an established patient relationship with a provider to provide telehealth services. Obviously, the payment rates are the same as in-person visits. That was very helpful. And then because we've got all this interconnectivity challenges, some of the HIPAA requirements that used to be challenging to work through, those have all been waived as well. And so we saw this great push through telehealth, and many of us, and I think all of you on the phone would say, the genie is out of the bottle. We're going to continue to see growth in this. We want to maintain these type of reimbursement levels, et cetera. The question now is to go back to your individual programs and make sure you're getting paid. What we're starting to hear is, yes, we're getting paid for the visits. Yes, we are seeing the same type of reimbursement for the visits, but because through a telehealth process, particularly if we delinked any requirements to come in for labs at the same time of a visit and delinked it from like the chemotherapy encounter, what we're actually seeing, if you allowed your patient to go to LabCorp or Quest in the community, get their lab, go home, have a telehealth visit, et cetera, and didn't have to come in to the health system or the cancer center for their labs, that's where we're seeing the revenue loss as well. So some of the larger systems have started to project that even with telehealth, I'm still going to see a 20% reduction in reimbursement for my overall service because I'm not capturing as many labs as I once did. And so that decoupling of, well, on one hand, maybe not requiring a patient to come in for a physician visit, labs, and chemotherapy all in one day, and maybe decoupling some of this and being able to improve scheduling, particularly around the chemotherapy encounter or visit of that day or treatment of that day, may be very helpful to you all. What we're seeing is that the advances in this, again, have been great, but there may be an unintentional revenue impact given that patients may be receiving services closer to home. Again, for the safety of patients, for the safety of your staff, for the right type of ways to have patients continue to get your treatment, that may, you know, be the reasonable price to pay in all of this. But just a comment, as you're looking at your numbers and managing what's going on, may see a hit on the lab side, is just an observation. A quick comment, I know we spent a ton of time talking about telehealth visits. I just wanted to point out the virtual check-in. For those of you that have nurse coordinators that are spending a ton of time on the phone, for e-visits that may be provided in other ways, particularly the virtual check-in, if that is for, that's also any type of call in, and a practitioner is more than just a physician, obviously you can get paid for those types of services as well. So just make sure you've got all these things lined up in your service. To continue on, wanted to quickly hit and highlight that probably the best source, one of the better sources of compiling all of these types of operational changes is actually the ASCO's Guide to Cancer Care Delivery during the COVID pandemic that I believe was included in some of the, as a handout to this webinar. There are great links to examples, to suggestions around policies and procedures, how to address certain things within your cancer program that would be helpful. And so we tried to pull a couple out here that were being used in certain ways across the country as sort of food for thought as you're navigating back towards a full complement of services. So obviously we've talked about reducing the on-site amount of clinical encounters by embracing telehealth or virtual care strategies. This notion of transitioning certain services to alternative care settings. Obviously, I mentioned the local lab services. You know, there are also virtual medication management services that are out there. We are seeing a lot of this pushing of different types of services in different places of the cancer continuum and pushing that into that telehealth environment or alternative environments. And so how does that then manage capacity when you think about the footprint that you have, the amount of patients and staff that you want to manage through your facility? I think social distancing, when we get to that, just like many of you, if you look at other organizations that are opening up, what we're seeing is that the schedule of patients and doing anything that you can to have it off stage, all of the phone calls, all of the scheduling of patients, collecting copays, registering of patients, there should be no more front desks now. Can you move that all off stage? Can you move that virtually? How many people are pulling things together into a centralized call center or offstage call center or online registration modules has been the big push over the last few weeks. So how can I virtually replicate the front desk in an alternative way? Obviously, they're seeing lots of folks around reducing the number of infusion chairs, reducing the number of exam rooms, putting space in the clinical areas to accommodate the social distancing requirements. When we think about addressing bottlenecks, I talk to folks are doing similar types of things, extending operating hours, implementing time blocks between patient visits and treatments so we can turn the chairs, turn the rooms, make sure that our cleaning protocols are all in place. The one thing that people sort of chuckle about is the update of signage. You know, you may not think that everybody's probably racing to manage all of this. Folks are saying, my signage budget, I needed to really and make sure that the right type of signage was there to help inform both team members and patients of how to do this. I think as folks are getting more comfortable as they're experiencing this in other types of business arenas, but obviously just a comment around getting patients and at a certain time, family members aware of the social distancing requirements. At smaller cancer centers, we're seeing a lot of folks push patients out of the main center, maybe to community-based networks, home health. There's all algorithms to move patients to, said some people we're going to be the COVID-free center. We're going to have dual tracks for COVID and non-COVID patients, particularly in cancer. I think this is where you've got to see, well, what can I do related to utilization of space, staff, et cetera, to manage those care avenues. Obviously, we've seen folks try to take care of patients with significant cancer and urgent cancer needs. And so are there surgical alternatives? Are there ways to maximize treatment modalities given the different types of cancer care that you're being provided? What we often are asked most and what people are sharing notes about are COVID testing guidelines for asymptomatic patients and staff. How do we test? Where do we test? Are we testing every 2 weeks? Are we testing every day? How are we taking temperatures every day? Are we taking staff temperatures every day? Again, the ASCO's guide had a couple examples in it. What we predominantly heard is staff is being tested every week or every 2 weeks. Patients are being tested similarly. And so it really depends on how your organization is managing these expectations, particularly given where you are in the country. And again, if you're in one of the hotspots, this may be different. If you're in a different type of situation, maybe there's a different type of policy for you. But I think folks are making reasonable attempts to make sure that we increase testing across the board, and we obviously have to sustain testing as part of the sort of the new normal moving forward. Visitor policy, this is again just what is hitting folks the most. How do we manage this given these are our cancer patients? They rely on family members as part of their care team, and it is a challenge not being able to have them within the organization. And so some folks are starting to allow in a visitor per patient, obviously implementing all of the testing and the use of PPE. Others are looking more towards the fall. I think what we're seeing is an uptick of obviously e-chart messaging with family members, aligning the clinical teams to more proactively communicate with families, pushing different types of communication strategies back out to families, given the situation. And so while there's not one size fits all, particularly in those environments that have challenges through all different types of language or interpreter needs, this is where we're also seeing how do we increase our use of phone or telehealth messaging with core patient family members to provide them their support. I think we've tried to give you that very high level overview. Many of these things we would think that you all are doing. For the first polling question, just wanted to get a sense of the group. What are you all doing? So select all that apply. You don't have to select just one, but when you think about increasing capacity or being able to see more patients as you're taking on this sort of patients coming back to you over the next several weeks or months, are you extending operating hours? I'm certain that everybody's already expanding their virtual care offerings, but are there alternative settings? Are you shifting busy patients to less busy clinics? Are you modifying any of your clinical portfolio protocols to accommodate the changes in the care delivery model? Jim, we'll give it another minute. And go ahead. Yeah, I think this is everybody's trying a bit of us. I like that everybody is extending their virtual care offerings or at least has a virtual care offerings. I think this challenge of how do we change our practice, change how we're treating patients, how we're managing patient flow seems to be on top of everybody's mind. And about 40% of you are extending your operating hours. I'm interested in that shift of patients to less busy clinics. That could be through the day or through the days of the week, or it could be obviously locationally by location, which locations you're pushing to, and then modifying your clinical protocols given what's going on. Maybe the next polling question. We're going to ask of everything, what strategies, oh, I think it's the next one. That would be my fault. Of the operational challenges that you've implemented, what do you think are going to stick? What's going to be adopted in the long term? I think, we've talked about it. The use of telehealth seems to be the genie's out of the bottle. Non-essential employees working from home, something that we're seeing for a rev cycle, something that we're starting to see for some of the other alternative, maybe sort of off-stage resources, nurse triage, nurse call, social work, et cetera. PPE management policies, how are we keeping our staff and our team safe? Extended operating hours, and then alternative options for patient queuing. This one, a lot of text, I think the folks are leaning more on multiple device texting or virtual waiting rooms. I think handing out pagers like we did in the past, well, now you have all the cross-contamination. We have to keep them sanitized, et cetera. So may still be using that as a model, but we're starting to see people push on the virtual waiting room, the call in, we'll text you to come in, we'll text you when we're ready and go from there. Jen, do you want to open it up? Use telehealth and then alternative options for patient queuing. Great, that would make sense. And then followed, around the PPE management policies and the non-essential employees working from home. I think at this point, before I turn it over to Matt, we wanted to open it up. Nancy, do we have any questions that we want to quickly run through?
You do.
Okay.
The first question that came in relates to the billing for telemedicine, and the question is the 20% reduction in services for telehealth you referenced tied to site of service?
No, I apologize. When you, it's not tied to site of service. What I was tying it to is people not receiving their services at the cancer center or the health system like they would in one-stop shopping. That 20% hit is because people are going out to receive labs from LabCorp or Quest. It actually not related to the site of service differential. In that example that I gave, it was more I'm getting services locally from some other provider than of you. But I could understand where the site of service hit would hit.
Thank you. The next question is anyone implementing or expanding home infusion therapy services?
Yes, we are seeing a lot of that nationally. The challenge is the home health rules are state by state. There are, I believe Oklahoma does not have a home health company agency, didn't have an option there, and to set one of those up requires significant amount of investment. And so we are seeing a lot of relationships built, for lack of another term. If you don't have those relationships in the area that you are, we are seeing closer alignment with those companies and agencies. But in certain cases, there's also a lack of options, and so that will be likely something for future debate and investigation to see how to maximize those types of services.
Thank you. Our last question that came in, I think it might have been at the time you were talking about this topic, was our center starting to test staff? And I think you touched on that. Can you provide any other clarification?
Yes, I think everybody, to be honest, everybody is testing staff, particularly the folks that are testing staff routinely, particularly of those folks in high areas of COVID diagnosis. But the thought is that the healthcare team should be tested routinely because of their close proximity to cancer patients. And so, yes, and I think the ASCO guidelines had some good outlines. I think, again, predominantly we're hearing testing of staff every 2 weeks. Again, looking at your benefit structure, understanding where that cost is going to come out, how to manage all that, I think would be the next question.
Thanks. Matt?
Very good. Thank you. So at this time, we're going to turn and talk about some other aspects of the recovery and preparing your operations. I think before stepping in, one thing to kind of call attention to is, as we're thinking about the next stage of cancer care after the public health emergency, there's really two substantive forces or challenges that programs need to be prepared to address. One is, as Jessica mentioned previously, for a period of a couple of months, so substantively March and April, all of the data that we've seen suggests that most programs saw a reduction in outpatient volume on the order of 40 to 50%. We've seen data that suggests other providers, other services saw similar, and in some cases higher reductions in volume. The implication of that is that while many patients remained on treatment, your chemotherapies, et cetera, continued, a lot of the upstream identification of new cancer patients was interrupted. And so the implication is we're expecting a surge or a bolus of patients who ostensibly put off care for a couple of months to be making their way through the system in the coming months. The flip side to that is creating a space that is physically safe from an infection control perspective for your patients. And so the practical reality is, we're probably still months, if even a year or more, out from a vaccine and or substantive treatment for the disease. And so in that time period, we'll continue to operate in this environment of exercising extreme caution from an infection control perspective. And so that really is the yin and yang that programs need to be very thoughtful in addressing, both reducing capacity in some regards physically, but at the same time also allowing for providing care to more patients. So the implication now as we turn and think specifically about your facility, what we're hearing from folks is a variety of strategies that are being implemented. So clearly social distancing applies in the clinic. We're seeing a variety of initiatives being pursued, from erecting physical barriers at check-in points to spacing out chairs in the waiting areas or so forth, or even in treatment spaces such as your chemotherapy suite. We're also seeing alternative strategies related to how we queue up patients. So whether that is having patients wait in a remote space, whether that is re-examining your operations to get to more of a just-in-time, real-time model, and providing more clear direction to patients in terms of when they should present to the center. All of that designed to reduce the amount of people that are simply waiting to move through the system. We're also hearing from centers that there's this trend in terms of moving more services offsite. So Jessica talked about the use of telehealth, and that is a real strategy to alternatively provide care, as well, moving patients into satellite clinics, remote clinics, so forth, that can decant out of busier main centers of operation. We're also hearing that many programs through the COVID-19 public health emergency have been very deliberate in terms of moving administrative personnel or non-essential employees out of the cancer center. So those may be administrative people, it may be some of your revenue cycle staff, cancer registry, a variety of personnel. And in a number of cases, we're hearing that this may be a longer term strategy for the organization, not only as we live through subsequent phases of COVID-19, but potentially longer lasting, as it has implications of freeing up physical space for other purposes. But in the current environment, as you look at the facility, as you look at operations and the space that's been made available by decanting personnel out of the center, there may be opportunity to repurpose some of that space for other activities, clinically or otherwise. Other strategies that we are seeing, so we've heard some of our clients talking about the use of air pressure in the clinic environment as a tool to provide enhanced infection control, so either positive or negative air pressure to move air through. We talked about the telehealth and virtual care. Again, really the notion here from a facility perspective is oriented around transitioning patients out of the facility as makes sense, while still providing appropriate care. And then lastly, I think it's important to begin thinking about your parking situation. Many centers that we work with, parking has been a challenge historically, and the extent to which you're re-examining throughput and so forth, if there's intended to or contemplated to be more patients moving through a higher throughput rate, not just extended hours, but increasing the rate of patient throughput, you may need to re-examine opportunities or other ways to provide parking solutions or transportation solutions for patients as well. You may see a net increase in the use of personal motor vehicles, as patients may be reluctant to use public transportation or other means, which then increases the demands for parking. So at this time, we're going to pause for our next polling question, and I'll ask Jessica for some help to walk through this. But ostensibly, the question that we're asking is, what policies do you anticipate continuing or adopting in order to protect patients and staff in your center? So this is really focused from a facility perspective around an infection control perspective. Okay, Jen, if we can go ahead and close the poll. And Jessica, if you could add any commentary on what we've seen.
I think this is, you know, the limitation of visitors and caregivers are predominantly what we're seeing through the fall. And it may be, I think the challenge is this until we have a vaccine? And then how does that impact, again, more of just the communication strategy of your care teams and how they're aiming to keep sort of the families and the other team members as part of the care team, the families and their significant others, involved in care decisions or involved in helping to, again, move patients back and forth, provide transportation, et cetera, beds, et cetera. I think all of the other elements are exactly as we've seen, and we've discussed a bit earlier in the presentation, in the relocation of non-essential employees. I think this is where, unfortunately, we may see some significant outsourcing of services as an outcome of very large systems having to manage cost. We're all feeling the impact of this volume not coming through the cancer centers, not coming through the rest of the health system. And so particularly those centers that are looking to manage cost, outsourcing or managing certain back-end services in a different model, different way, seems to be something that's gaining steam.
Perfect, thank you. And before we move on, Nancy, have we had any questions come in related to facilities? Okay, hearing none, we'll move on. So we have a brief little case study here. So as Jessica mentioned, we've been talking with our clients all over the country, really to understand what they're seeing and experiencing with respect to COVID and recovery and so forth. What's highlighted here is a large cancer center located in the Northeast. They were in a market that was hit particularly hard with COVID-19. And it's interesting to note, I think as a case study and things to keep in mind, you know, for the future, if there should be a significant recurrence that happens in your community, how centers in areas that have been more heavily impacted have responded or addressed issues. So from a facility perspective, you know, a handful of things noted here: the way that they shifted capacity around, creating dedicated spaces both within the hospital as well as within the cancer center for COVID-19 patients. They actually, their incidence was high enough that it directly impacted some of their cancer patients, and so they developed policies and procedures and spaces to be able to manage those patients within the center. Including things such as separate or dedicated circulation for the patients, where they came in through separate entrances, and both from an ingress and egress perspective. They had a individual who would follow their COVID positive or suspected patients, and literally would clean behind them as they went. So as elevator buttons were pushed and so forth, they would be sanitizing those spaces. And then, as I said, there was also a dedicated space in the clinic And you see here how they approached nursing staff managing those patients from a reduction in PPE. So they had like a cube, a glass cube that the nurse was able to interact with patients, and that then helped to minimize the use of PPE in that space. These were really kind of surge strategies that they used at the height of COVID, and they're planning to disband once the volume subside. But again, interesting case study to reflect on if it should become of need in your community. Next, as we think about other implications of COVID, so communication is critical. I think thinking about your patients in particular, letting them know what to expect before they come to the cancer center, what the environment will be, how operations have changed since perhaps they visited previously, expectations around whether or not you're allowing visitors or not, limitations in visitor policy, et cetera. All of that so that when they hit your door, they have a clear expectation of what to expect. With that as well is communicating to them how you're addressing their safety. What we're seeing is reluctance from patients, particularly from vulnerable populations, to come back for healthcare services. And so addressing those fears or concerns will be very important in terms of getting them back into the program. And then lastly, clearly the compassion piece and providing additional support to them, particularly in environments where you've had to curtail visitors. Workforce is another area that we're hearing a lot of increasing dialogue about. How do you manage your staff through this? This is a trying time for staff, and making sure that you're keeping those lines of communication open. You're keeping a attention to how they are doing. Issues in terms of managing childcare, at-home issues, et cetera. Just kind of the psychosocial aspects of this as well. And so keeping those lines of communication open with your team regularly is going to be important, as well as providing them updates about what you are doing to ensure their safety, as well, the extent to which you are looking into expanded operating hours. There may be staff who are more flexible. There may be staff who, due to work schedules of their significant other, it may be easier for them to work at differentiated times so that they can juggle childcare needs, et cetera. And so I would just encourage really taking this from a very proactive perspective in terms of that dialogue with your team. To that end, Joint Commission released a quick safety last week, specifically oriented around many of these topics. And there's a link here in the slides that you can pull down a copy of this and share with your team. But there were a handful of strategies specifically targeted both at individuals, healthcare providers, as well as strategies for leaders and managers to make sure that they are keeping an eye on the team. Again, the communication piece, and with a real eye to the social emotional aspect of this as we go through the COVID-19. Lastly, as we think through kind of impact and planning for the future, the financial piece is a critical aspect. So, as every program and every center has seen, the last few months have had a very significant adverse financial impact. And so planning for the future really needs to be top of mind right now for programs. And so what we encourage is that you all as cancer leaders begin that dialogue with your finance leaders and with managed care team. And so interestingly, there have been some strategies that payers have begun to put in place to help health systems through this time. We're seeing differentiated levels of participation in those programs by health centers. But what we haven't yet seen, and we are recommending, is that you begin thinking about how your care model is going to change going into this recovery period. So the extent to which, for instance, you're going to move to more home-based infusion or oral oncolytics or alternative courses of therapy, hypofractionation, et cetera. All of those, while having operational and clinical implications, also have financial implications. And so your payers are going to be more receptive to discussions about alternative payment models and constructs and so forth in advance than after the fact, because once you've implemented those changes in clinical patterns, they'll be thrilled with the financial savings that they're realizing. It'll be much more difficult to renegotiate or structure different arrangements. Lastly, on the 340B front, so there have been a number of changes, handful of key things to keep in mind as flagged here, but most notably is that HRSA announced early on in the pandemic that telehealth visits would qualify, it would meet the requirements for a patient to qualify for 340B drugs, provided that the provider was in a designated space, a qualifying space when he or she conducted that visit. So that is an important note. The other note, which is not specifically called out here, but is a recent development, even as late as yesterday, HRSA has posted information on their website that is effectively indicating that you may add new sites and be able to provide 340B drugs at those new sites, so long as they meet the requirements for provider-based billing. They do not need to be included on the filed cost report. They won't be listed as a child site per se until the cost report is filed, but HRSA and OPA, Office of Pharmacy Affairs, will allow you to begin accessing and dispensing 340B priced drugs in new sites that meet the provider-based rules. So that is a key development. Again, more information available on the HRSA website, but important opportunity to look into. Lastly, from a finance perspective, the oncology care model, the number of updates that have come about from this. Of note, they're reducing or eliminating the upside downside risk requirement for certain periods. As well, they've announced that they are going to extend the duration of the model for 1 year. So that will be going into June of 22 instead of 21. So with that, we have one final polling question before we wrap this up, and this is asking about what strategies you're considering in response to the public health emergency, financial strategies, that is. Okay, and Jen, let's go ahead and close that down. And Jessica, any comments that you'd like to add?
I think the reevaluating capital investments is one that we're seeing as revenues really dropped over the last several months. Folks are pushing out projects, evaluating if they need the same type of space, the same type of services, the same type of investments. I would say that reaching out to seek financial support for payers probably needs to be a push on all fronts by all, even if it is a year of can we reduce some of the administrative burdens related to our cancer care patients. We are finding that some payers are listening. Of course, that's market by market. Of course, that is payer by payer. But I would just be an advocate for folks reaching out to their payers in the local market and saying, look, what can we do? And expanding on that conversation.
Perfect, thank you. And we are running up against the end of our hour. So last takeaway here on slide 30, just I think this provides a framework for you all as you go back and have conversations with your team. really the 4 pillars that you need to be thinking about as you're planning forward are going to be the operations, how you're addressing that, the facility, the physical environment, how you're managing your workforce, and then obviously, or firstly, are the patients, and keeping both safety and other issues in mind for them. So I know we've run right over. We have included in the packet materials contact information for both Jessica and myself. And so if there's questions that were asked and we didn't have time to get to them, feel free to email either or both of us. We'd be more than happy to take those questions offline as appropriate. With that, Nancy, I will turn it back to you.
Nancy, maybe.
Thank you very much, Matt and Jessica. We'd like to thank everyone who participated today and hope you can join us for ACE's next webinar in the series, Delivering Cancer Care in the COVID-19 Era. That's session 3, Imperatives for Health System Success and through an Oncology Lens. That webinar will be on June 24th and will be presented by Chartis. We also welcome and encourage our members to submit webinar presentation proposals. We'd love to include you in this series. Jessica and Matt, thank you so much for a presentation with a lot of terrific information.